Hello, my name is Dr. Deborah Cohen, and I am the MAVEN moderator for today. Thank you all for joining us today and our friends at the Manet Community Health Center, who is our anchor clinic and is hosting today's session, Assessing Common Motor Problems in Children with Dr. Lynn Kerr. Dr. Kerr is a pediatric neurologist in Salt Lake City, Utah, and is professor emeritus at the University of Utah. She is interested in child development and genetic syndromes that alter the typical trajectory of development. She has been co-director at the Shriners Hospital Neuromuscular Clinic, where she has worked with patients and families with chronic conditions such as Duchenne muscular dystrophy and spinal muscular atrophy. And with that, Dr. Kerr, please begin.
Good morning. This is very strange because I don't see any faces, I guess because I'm sharing my slides. So as Debbie said, Lynn Kerr from Utah. I worked at the University of Utah at a children's hospital, but I also worked at a Shriners Hospital where we gave free care to kids. And that has really colored my experience as a doc. It was amazing being able to get free care. And as I sit here worrying about what's going to happen to care going forward, I particularly worry about that. And Debbie, this is not advancing. Okay, so no disclosures. Yet one category, one CME. So we're going to talk about motor problems in children. Children are really hard to look at, but because there are so many different things going on. My main objectives that are written in the language that I have to do to get you guys category 1 CME are to recognize abnormalities in the physical exam of infants and young children, to apply this knowledge to evaluate possible conditions, and to apply this knowledge and demonstrate what to do if any one of these conditions is expected. So these are common motor problems for me as a pediatric neurologist, but obviously not for you. But I'd like to give you kind of a framework. Some of them are as frequent as 1 in 1,000. Some of them are the most frequent killer of babies under 1 year, frequent genetic killer, that is. Some of them are occurring less commonly, but now that we have treatments are very important to be able to recognize. So let's just start with this example of a 2-year-old boy not walking. So many questions to ask. Did he ever walk? Is he developmentally delayed? Maybe he was born without a foot on the right. He had amniotic band syndrome and he gets around with crutches. How long has he not been walking if this is just a regular walking question? Did he fall and hurt something? Did he get into family medications? Is there a family history of kids walking late? Was he premature? Are there any associated symptoms? So just a really complicated way to think about it. The bugaboos in this are that kids don't come in and tell you that they feel weak. And so you also have to think about what are they doing compared to what is expected. If a 5-month-old baby is in front of you and the parents are concerned that he's not walking, that's really different than a 2-year-old in front of you not walking. The other problem is that in infants, we look at tone, which is resting tension in the muscle, as well as strength. And strength is how much force the muscles can exert. I'll show you some cartoons of this because it's kind of hard to think about, I think. The other problem is that infants are often asleep. In some ways, it's kind of nice to have them just sleeping in mom's arms, but to look at them in terms of their development and their movements, you really have to unbundle them and put them on the exam table to observe them. The other problem is that you can't ask a 2-year-old to do finger to nose testing or push against your hand. You just have to watch them a while. And all those things just make it difficult. So what's involved in movement? Essentially everything. The central nervous system, the spinal cords and peripheral nerves that carry signals to and from the brain and to the muscles, the skeleton for the muscles to attach to. And then all these things need energy so that the muscles can move. Also, the body needs to know where the body is in space so that the muscle knows where to move next. and then genetic conditions that can affect any or all of these. So let's start with infants. To, again, take off their clothes, be able to watch them, wake them up. So the baby on the left with the blue and the white shirt has very appropriate tone, so resting tension for an infant. So he's sitting there, hands together, feet and legs curled up. The two babies on the right are splayed out and are showing poor tone. We don't know how strong they are. Maybe when they move, they actually have some strength, but at least the resting tone is very low. We also have to look for symmetry over time, and I'll show you a slide to show that next. And then can they move their arms and legs with good strength? So you may need to ask the parents about that one, because you're not going to agitate the baby enough probably in front of you to see whether they're moving with good strength. But again, tone is different from strength. So this reflex, the tonic neck reflex, makes muscle movement symmetry difficult for all providers. For the first 6 months or so of life, babies awake like to have their hand behind and looking at their outstretched arm. So that looks very asymmetric, but maybe you look 2 minutes and then it's the other arm. So that's okay. So you have to watch for that symmetry over time. Asymmetry can be a very important sign of hemiplegia, so really important to look for. Not to belabor this, but tone again. The normal baby put over a hand, even a newborn baby, will keep a good posture, whereas a floppy baby or baby with low tone will hang over in kind of a C position. Even newborn babies, if you pull them up by their arms, like in this slide, should have a little bit of an attempt to keep their head up on their shoulders. So this baby has hypotonia. In addition to symmetry and tone, again, you have to look at what they're doing developmentally. Best to look at a chart. I'm going to be showing you some milestones, but my favorite more in-depth charts are those from Healthy Start, which are put out by the American Association of Pediatrics. Then check their weight and length. So if they're very short, but high in weight, it tells you differently if both of them are down. Also check the reflexes, which are usually pretty easy to get in a resting awake baby, and they should be present and equal. Gross motor milestones. So newborn has head lag, but should make a little bit attempt to move its head, moves arms and legs equally, ignoring the tonic neck reflex. At 3 to 4 months, their head should stay up on their shoulders. They should start rolling belly to back. At 5 months, they should be able to roll back to belly. At 6 to 8 months, they should be starting to sit. By 9 to 11 months, crawl and cruise along a couch, for instance. 1 to 2 years, they should definitely be walking, doing stairs with help, and bend over to reach something and then stand up. By 2 to 3 years, this all should be getting better. They should be able to run, jump, tiptoe when shown. By 3 to 4 years, balance on one foot, ride a tricycle. And by 4 to 5 years, go upstairs, alternating feet, not just putting one step, 1 foot up, the next foot up, 1 foot up. So a baby that, I want to go back to that slide a minute, a baby that doesn't do one of these things, for instance, they're cruising and not crawling, or they're not able to tiptoe when they run and jump. You have to take all this into a little bit of perspective. Missing one thing is not necessarily important if the general trend is good. Fine motor developmental milestones, babies that are born like to have their hands fisted and bring them to mouth. By 3 to 6 months, they should be able to get their hands all the way to the midline. If you put an object in their hand, they should be able to grab it briefly, and they're starting to transfer from hand to hand. By 6 to 9 months, if you put something like a Cheerio in front of them on a high chair tray, they should be able to rake it, and then they start being able to do a pincer grasp, and then they should be able to hold 2 objects simultaneously. By 9 to 12 months, they should poke and point, put small objects in a cup, turn pages of a book, especially if the book has a little bit thickened pages. 12 to 18 months, building a tower using a crayon. And by 18 to 24 months, having a hand preference. Some kids do it later, but the important point is if they get a hand preference before 18 months, that is a sign that you need to look into, check the reflexes, make sure it's not a problem. And I'll be doing a case about that in just a minute. Speech and language, I won't go all through these, but as time goes on, they should start being able to do words, putting words together, following commands. So then I'm going to do some cases. A 4-month-old baby is brought in by parents as he's floppy and not gaining weight well. The baby was born at home without prenatal care as the family doesn't have insurance. They tell you that the baby was growing well compared to the mom's other 3 pregnancies until the last couple of weeks. On physical exam, the baby's floppy, lying awake with arms and legs splayed. He's not moving much. So one question that you should be thinking here is this developmental delay or is it weakness and low tone? The baby looks unusual to you, has a single transverse crease on the left palm, and there's the top picture, the top right picture shows a single palmar crease. The right palm looks typical. He's not particularly alert. He's awake, but he's just kind of sitting there looking into space. So the most common causes of low tone floppiness in babies are various genetic syndromes. The one that you're most likely to see is Down syndrome. Prader-Willi is also famous for this, but others as well. And as you know, there are so many syndromes. The incidence of Down syndrome varies according to maternal age, but is about 1 in 1,000 live births. The other common thing are metabolic problems, such as hypothyroidism. Newborns are checked for this, but this baby was born at home. However, mom had told me that most home births occur with, or she had a home birth with a nurse midwife, and most of them will work with the state health department for newborn screening. And then, of course, multiple brain and muscle abnormalities could also be possible. So in Massachusetts, if an abnormality is identified on newborn screen, the state of Massachusetts contacts both the primary care and a specialty provider. They together come up with a plan. One of them is going to be put in charge of contacting the family with that plan, which may have to include repeat testing, since a lot of these tests are screening tests and need further elucidation. They also might refer the child to a genetic counselor. There are 32 conditions screened for an MA, and just always check that a child has had newborn screening. I was involved not as the doctor that forgot, but the doctor that got called to trial, and a pediatrician here that forgot to check about hypothyroidism in a child who was not picked up until about 18 months of age. So this is a list of conditions found by newborn screening. They are by category. So many things could be causing this baby's floppiness. And then there are a lot of ones in here that I'm sure you all know: cystic fibrosis, sickle cell disease, not common in Utah. And then I want to note in the yellow down here, spinal muscular atrophy and Duchenne muscular dystrophy have recently been added to the newborn screen. This is really important, and as these 2 conditions now have treatment. And the other thing is that I would like to give a shout out to the family foundations for these 2 diseases that have worked with states and federal governments to get these added to newborn screen. So Debbie, I don't know if I can do this, but are there any questions before we get to case 2? I'll assume no. Okay, case 2. Case 2 is a 3-month-old baby lying in a frog-leg position, but looking very alert and interested in you. The baby looks skinny. When you look at a weight chart, you know that the weight is only 10th percentile. Parents tell you that the baby has seemed different from their first child since day 1, floppier and not moving much, but has been getting worse over the last 2 weeks. Parents also tell you that the baby never breastfed and that bottle feeding is taking longer and longer, and there's some coughing with eating. So important findings when you actually do the physical is that the baby's just lying there. You can see in this picture, which is a picture of a child with SMA, that muscle mass is decreased. He's had poor weight gain. And then when you keep on looking at him, he's breathing really funny. And you notice that his chest is not really going up and down, but that his abdomen is going up and down. It's abdominal breathing instead of typical breathing, a common finding in a newborn with this condition, which is, of course, spinal muscular atrophy. So SMA, or spinal muscular atrophy, is a genetic disease affecting the peripheral nervous system and then the muscles. The muscles atrophy because the nerves that go to them die. There are three forms: infant, type 2, and type 3, but I'll be concentrating on type 1 in this lecture. So I have seen so many of these kids die over the years. I first got interested in neuromuscular conditions when I was in medical school. And kids with type 1 SMA, unless their parents chose to put them on a home ventilator or put them in a nursing home with ventilators, they would die before 1 year of age. This is an autorecessive condition, and although 1 in 6,000 are born with it, 1 in 40 people are carriers. And SMA is the most common genetic killer in the first year of life. So this is a cartoon of what is affected in SMA. The spinal motor neurons, or anterior horn cells, that go from the spinal cord to the muscles die in the first few weeks after birth, apoptosis, to allow fine-tuning and coordination of movements as the baby develops. And that happens in normal babies, but it's only a small fraction of those that die. In SMA, kids with SMA are lacking a protein that helps keep them alive, and those spinal motor neurons die off very quickly, leaving the child weak. Those spinal motor neurons also go to the muscles of the throat, making it harder for them to breathe and to swallow. So in SMA, intelligence is not affected. I already told you it's caused by a deficiency of the spinal motor neuron protein. Its deficiency is caused by mutations on chromosome 5 in a gene called SMN1 for spinal motor neuron protein. And it's a really complicated genetic situation, which unfortunately has made treatment much more difficult than we were hoping when we started thinking about this, like in 1980. So there's also another gene called the SMN2 gene that can in part compensate for the lack of the SMN1 genes, but babies with type SMA have little or no of the SMN2 protein. Kids with less serious SMA, who might still be alive, although in wheelchairs in their teens and 20s, will have more SMN protein. So there are now several genetic treatments for SMA. I'm going to talk about Zolgensma, the least complicated one and given once. So this is done by IV. The last time I checked, it was $2.3 million for one-time application, but babies who would have died at age 1 are alive years later. We don't have a lot of long-term data, and they're certainly not normal for age, but they're often walking and they're not on ventilators. So because we have been interfering with the type 1 or fatal type of SMA, we've now changed our classification in the United States to children who learn to sit, children who never learn to sit, or those who learn to walk. In other countries, especially in non-EU countries, this drug has not really hit yet, and they're still back in the old classification. We do know after using these treatments that the earlier a child gets treated before a lot of the motor neurons die off, the better they do. So giving them at 1 week after birth is much better than 3 weeks after birth. So insurance pre-authorization causes a big problem if it takes us a couple of weeks to get approval. And of course, with that expensive a drug, insurance is going to want to do pre-authorization. That's one of the reasons that the families wanted to get this on the newborn screening panel. And it's a reason why some centers are now trying to give the Zolgensma before the baby is even born, before that pretty close to newborn die-off of spinal neurons occur. So in this particular case, diagnosis and treatment is an emergency. So the earlier the treatment, the better the outcome. And genetic testing is easily available. And this little girl is getting her mouth swabbed. The cost is in hundreds and not thousands. If a child is referred by phone to a neuromuscular center, there are many all over the country. They will help arrange all that, and they can help with financial arrangements as well. Cure SMA is another organization. I'll put these at the end of my talk, so you guys will have them. Again, genetic treatment is available and life-saving. In Massachusetts, but not in all states yet, you may also find out that a baby in your practice has this diagnosis by a positive newborn screening test. If that's the case, the health department will contact you with further instructions. And diagnosis by newborn screening will enable Zolgensma to be available sooner after birth. Okay, that's SMA. So this is another case, same age child. So a 3-month-old baby also lying in a frog leg position, interested in you, but with little movement. He seems sleepy. His eyes are droopy. Parents tell you that the baby was completely normal 1 week ago. And you kind of look at them like, really? This baby is so not moving and so abnormal. But okay, baby was normal a week ago. You try to get reflexes, you're not able to get any reflexes. And you note by watching the baby over a few minutes, very few movements. So the parents tell you that the first thing they noticed was severe constipation. He also didn't seem to want to keep his eyes open. Then they noticed that his cry was weak, he was swallowing poorly, and had a gradually weakening body. So you're sitting there watching the baby, and you notice that he's having trouble breathing with fast, shallow breaths. You get a pulse ox to put on him. It's very low, and you call the EMTs to come in. This child needs emergency ventilation. So this child has infantile botulism. We used to get cases spread by honey when I was a medical student. We know enough to tell parents not to do that anymore, but dirt spores are still all around. We get them commonly in the spring from farms like in Wyoming and Idaho around here, but also sometimes in new developments where there's a lot of dust being kicked up by construction. So the spores produce toxins in the colon, which block the neuromuscular junctions between the nerve and muscle cells. The peak incidence is at 13 weeks of age, so you're not going to see this likely in a 3-year-old. Causes extreme constipation, cranial nerve, and then body weakness. So often these kids will need their airway to be protected with a ventilator for months. If they are diagnosed and given antitoxin, which is called big IV, they may recover in weeks. Swallowing is kind of the last thing to come back, and a lot of times these kids, even after they're not on a ventilator anymore, still have to have a feeding tube to prevent them aspirating their liquids. Diagnosis is by AMG, and it's a pretty easy diagnosis to make with that, although obviously hard to get, and a stool sample. Although with constipation, it is so difficult to get a stool sample. Most babies, you get a stool sample in a few hours after you want it. And here, it's just very difficult to get. Case 3. Case 3 is a 1-year-old girl whose parents state that she isn't moving her right side as well as her left. She's been left-handed as long as they can remember. She also has strabismus, and you can see this cute little girl down here has eyes that are not moving correctly together. They've brought this up to their pediatrician, who thinks he's just going to watch her. He's okay with this. So when the parents bring her to you for another person to take a look at her, when you examine the child, the right leg looks a little bit smaller than the left, and the reflex on the right side is increased compared to the left. She uses her left hand almost exclusively, but she's very good with using her left hand and does things appropriate for age. She's interactive and makes a lot of noises, and you feel, at least without further testing, she is pretty much developmentally appropriate. It turns out that this young lady has hemiplegic cerebral palsy. CP is the most common cause of childhood injury, leading to things like spasticity, hemiplegia, and by itself, CP only means a non-progressive injury to the brain. By itself, CP has to occur at or near birth, and it limits mobility. So CP can be associated with intellectual disability, eye problems, epilepsy, but these aren't part of the diagnosis. All they need is the motor problem. So when you first see a child and think that they have CP, you have to consider what the underlying causes of the CP are. The workup's important, although not as emergent to find the etiology. but to ensure that there's no further treatment for the underlying condition. For instance, a kid with hemiplegic CP might have a tumor on one side of the brain, and obviously you have to have that tumor found and treated, whereas genetic conditions or prenatal stroke or intraventricular hemorrhage don't really have any treatment for the underlying condition. Treatment is needed for the CP and associated conditions, though, such as PT and OT for spasticity. The child might also need injections or surgery for that. Speech therapy to help with speech delay, OT to help with their hand movements. So this is not like a big emergency, but it is something that you want to do over the first about month of life. Parents will, of course, want the answer right away. So this is an MRI of a child that's had an intraventricular hemorrhage. You can see that if you look up into the brain, the right side is on the left and the left side is on the right. So this baby has had a right-sided intraventricular hemorrhage. So it doesn't correspond with my case. I'm sorry about that. I just noticed that last night. And you can also see from the sagittal section that the corpus callosum is very thin and has been damaged. So hemiplegia is often not noticed until this child starts preferring one hand much earlier than they should, with the normal being almost 2 years. This is the most likely type of CP to have no intellectual disability associated with it. So important to know that there are types of CP without intellectual disability, but also to get these kids help with developmental like PT, OT, and speech as soon as possible. There was a man that still is a pediatrician in Southern Utah that was in my class with hemiplegic cerebral palsy in my medical school class. And this is just the boy with hemiplegia. You can see his left hand and arm look pretty normal. And he's really good with that. He's a normal, really fun kid, but his right hand is spastic and contracted. So what is there to do for the child with cerebral palsy or other developmental delays? So you guys probably know about these, but there are early intervention programs providing services for children under the age of 3 with developmental delays and disabilities. They meet with the child and family. They come up with the range of services to meet those needs. So for instance, if they only have motor problems, they don't need speech therapy, but they'll come up with a plan. The goal is to minimize the effects of the delay over time. Early intervention programs are available in every state. They're available in rural areas too. And Utah has pretty rural areas, and we're still able to get these services. Early intervention programs for now. I'm a little bit nervous about this, funded by the federal government. Each state runs the programs differently. To access, you can just Google early intervention program and the name of your state, and then you'll get the ones for different locations in your state. So even if there's a child that's in your practice that you have concerns about their development, even without a diagnosis, for instance, a child with what you think is language delay, they can do an evaluation and then follow that child. It's okay to be wrong. The child could be completely normal, but they'll check in and help you with that. In many states, including Utah, I'm not sure about Massachusetts, sorry about that, parents can self-refer, so check the rules in your state. Those programs have been invaluable for many of my families. Case 4 is a 3-year-old boy who walked a little late, has mildly delayed speech, and he's not running like his other kids in preschool. The parents bring him in to see you, and they say, boy, you know, he looks really strong. And this is a picture of his calves. And indeed, his calves look quite developed, which would be unusual for like a 3-year-old boy anyway. So when you look at him, his heel cords are very tight. You can't bend his foot up well. When he walks, he waddles. He's not able to run at all. And he has a positive Gowers maneuver. So these pictures of this boy is a 4-year-old boy attempting to do what we call a Gowers maneuver. I've asked him to lie on his back, roll over onto his stomach, and then get up. So you can see he has some trouble even rolling onto his stomach. And then when he gets on his stomach, he has great difficulty getting up, having to put his legs quite far apart, and then actually use his legs to walk his hands up in order to be able to stand up. Although when he's standing, he's able to put his legs back together again. This is a very easy thing to do in clinic. So this kiddo has Duchenne muscular dystrophy, or DMD, occurring 1 in 4,000 male births. So early features are the large calves, the difficulty running and walking, and the Gower sign. So these kids are often not diagnosed till 5 or 6, but they really should be diagnosed by about the age of 3, because the large calves, the difficulty running and walking, are very distinctive. And a reason to diagnose them earlier than after 5 is that we now have treatments for them. It's not as much of an emergency as SMA, but still we like to get treatment started as soon as possible. So the first thing we do for diagnosis is do a creatinine kinase level, or CK. It's available in any lab. And not very expensive, and then genetic testing by a mouth swab. The cost of the mouth swab is approximately $300 and does not require any expertise. And I know that's still hard for some families, but I'll be telling you about care centers that can help with the diagnosis and management. So DMD is a horrible disease. Again, one I got to know a lot of families when I was a med student and resident. I would be with those kids while they were 3, 5, by 8, they'd be in a wheelchair. And by the early teens, like 12, 13, 14, they would die, usually from cardiomyopathy, respiratory illnesses. They also get severe scoliosis. We're doing a lot better than we were when I was a med student and resident, and we'll talk about that in a minute. DMD is X-linked. Moms may have some mild features, and that's something that the care center will think about. But it can occur de novo or completely out of the blue in a family. It does not need to be from the mom. DMD is due to mutations in a gene coding for dystrophin, which is a muscle protein. Steroid treatment and surveillance for known problems, for instance, doing echoes yearly to look for a cardiomyopathy that's starting, help greatly keep these kids alive. New treatments are becoming available, and they should be followed in a specialized clinic. I just want to show you why those calves are large and how devastating this disease is to muscles. So every once in a while now, even with genetic diagnosis, we have to do a biopsy if the genetic diagnosis is confusing, but I'm just showing these so you can see what it does to muscle. So here's a muscle biopsy from a normal muscle. You can see there are pretty regular hexagons or pentagons, and then the white tissue in between is the connective tissue with some blood vessels and nerves running through. This is a picture from the quadriceps muscle of a 5-year-old boy with Duchenne muscular dystrophy. You can see that the muscle fibers, you can still see them, but they're all chaotic and not regular. They are surrounded by a lot of connective tissue. The white stuff is fat that is accumulated, and there are a lot of inflammatory cells. And more we are understanding that Duchenne muscular dystrophy is a disease of inflammation. This is the dystrophin gene. It is the largest or near the largest gene known to man. And there are literally thousands of ways that mutations can occur. The light blue is a normal gene. The dark blue below shows that exons 48 through 50 are missing. And that has caused the protein to be very short and not work very well. So until recently, the only treatments we had were prednisone or prednisolone. It did keep kids alive longer. So by the time I was an attending, kids were living into their 20s or even 30s with incredible care. They were walking longer. Instead of being confined to a wheelchair at about 8 years of age, they were walking into their teens. Because they were walking longer, they had less scoliosis. Their heart problems started later, and their lung problems also started later. And in fact, we are seeing many more lung problems now because kids aren't dying of their heart problems earlier. Steroids have their own side effects, though, including obesity and osteoporosis. And you might be able to tell kids that have a lot of central obesity in wheelchairs that they're boys with Duchenne. It's a very common appearance. The main reason that these kids are not kept on steroids are because of behavior problems. A lot of them have some autistic features, anxiety, developmental delay, and then they get steroids, even on a very gradually increasing dose, and their behavior becomes so horrible that the family says things like, "This is not my son anymore," and they go off these potentially much life-improving medications. There are other treatments, including a newer steroid, which just came out called Agamree, and that has been more helpful. It's still not perfect, but it will be an improvement over the next 10 years. And then a new medication just recently out called gavinostat, which can be used in all types of Duchenne muscular dystrophy, unlike some of the genetic treatment, and generally protects muscle function by decreasing inflammation. We don't have a lot of data on this yet, but it's very promising. So unfortunately, our genetic treatments that are now available are not cures, but they do keep kids living better longer. There's several available. A lot of them vary, just have to be with one mutation that we only see in about 10% of kids with DMD, but there is one that's pretty new, Elevidys, that can be used for all. And these are available at the neuromuscular centers, and there are programs for boys without insurance. And I don't know what's going to happen now, but we are taking still children that do not have citizenship papers or children that are waiting for asylum. And obviously all that is in flux. There are dedicated neuromuscular centers all over the country. And then there are also Parent Project muscular dystrophy clinics, Muscular Dystrophy Association clinic, and others. A child with suspected DMD should be seen hopefully within a few weeks. And if one of these clinics, whatever is easiest for the family in terms of being local, is contact, they will help with referrals, and they will also help with financial arrangements. Shriners Hospitals are some of the clinics that are doing this. And these are the websites. I also wanted to remind you that you may find out about this diagnosis from newborn screening, and they'll give you instructions on how to proceed. So these are just MDA Care Center locations. I look in envy at the ones that are available on the East Coast compared to the ones on the West Coast. On the other hand, I guess we don't have as many people out here as you all do, but there are often local clinics. I've used the clinic in Puerto Rico in order to be able to get a young girl from Mexico with type 2 SMA genetic treatment. So they're usually very helpful and, again, can help with financial arrangements. Okay, on to another case. Your next patient is a 6-year-old girl. You note that she has a long face, seems to be mildly intellectually disabled, has some drooling and ptosis. And after you look at her, you look at her mom, and you think, boy, she really looks like her mom. Physical exam findings, including that she's weak distally greater than proximally. When you give her a pencil or your stethoscope to hold, she can't really grip it very well. Again, she has the long, weak face, and she has myotonia. Myotonia is an inability to stop a movement once initiated. It's seen particularly well in the hands, where if you ask them to grip their hands, they have a very hard time releasing their hands. Hopefully you can see me doing that. When you ask them to close their eyes, they close them, but then they can't open them again for a few seconds. You can tap on their thenar eminence, and their thumb goes into myotonia, or you can ask them to stick out their tongue, put a tongue blade on their tongue, tap it, and they'll get myotonia in the tongue. I'll show you some pictures in a minute. You might think to check mom for these things too. You think about Duchenne muscular dystrophy and get a CK, but that is normal. So myotonic dystrophy is the most common muscular dystrophy worldwide, 1 in 2,300 people. It causes weakness, the prolonged muscle contractions, and the myotonia. Unfortunately, myotonic dystrophy affects the whole body. It's not just a muscle disease, even though we call it a muscular dystrophy. Even teens will get early balding, cataracts, cardiac conduction defects, early diabetes, weakness, tiredness. And they're often born with contractures in their feet, giving them club feet, dislocated hips, and other orthopedic problems. The tiredness is really pretty amazing. And often the moms of these kids have been thought to be making things up. They say that they will do things like do the dishes and then they have to go take a nap. And they really do have that kind of tiredness. So getting a diagnosis is very helpful for them. I'd also like to point out that the conduction defects can lead to frequent sudden death. Until this was better known in our clinic when I was in medical school and maybe residency, every year or so we would have some person that would keel over like on a dance floor due to a arrhythmia. And so if we know that these people have myotonic dystrophy, and if they get EKGs, we can know that they have conduction defects and get a pacemaker put in to prevent that. And it's usually very successful. I haven't heard of a death in our center for a long time. So myotonic dystrophy comes in a spectrum from congenital myotonic dystrophy, which just means it's diagnosed near and after birth, to very mild signs and symptoms. We even had somebody in their 50s get diagnosed for the first time. Obviously, more severe cases are more likely to be diagnosed early in life. And the types that are diagnosed in childhood are called congenital muscular dystrophy. That's all it means. It's not a real specific type. And these are two young women with myotonic dystrophy. You can see that they have similar faces. Their eyes are not open real well, drooling. They often have a lot of developmental delay, often in wheelchairs. So this is a picture of myotonia. The one on top is the hand myotonia. She was asked to grip her hands, and it's going to take her a couple of seconds to release. And the one down in the lower right-hand corner is a tongue that has been tapped with a tongue blade to show the tongue myotonia. And that will take, oh, I don't know, 8 or 10 seconds to go away. So it can really be amazing. And you don't obviously have to know about EMGs, and we don't do them very much anymore, but I just think it's really interesting. So the bottom graph shows a normal muscle that is being shocked by a little bit of electricity every millisecond. And you can see that the muscle does a reaction to it. There's electrical reaction, and then it goes back to normal. Electric reaction goes back to normal. On top, the muscle fiber has been given one shock, and it goes into this giant discharge lasting seconds. If you could hear what the muscle was doing, this would sound like a dive bomber, like kind of like a bomb in World War II. Myotonic dystrophy is an autosomal dominant condition. So if one parent has the condition, the child will have it too. And it is a 1 in 2 chance of having it. The sex of the child doesn't matter. So in the top, we have that the mom had it, gave it to 3 of her 7 children. One of her male children gave it to 2 of his children, and then 1 female gave it to a male. So either male or female. The only change in that is that myotonic dystrophy shows a phenomenon called imprinting, whereas if the child gets it from mom, the severity will be worse. And we see this just over and over again. So this is how you can have a severely affected baby with myotonic dystrophy in the ICU, and nobody has even realized that mom has the condition. So congenital myotonic dystrophy, the babies can be born weak with decreased ability to breathe. So think about this condition in a newborn with a lot of difficulty breathing, maybe needing to be on a ventilator. Little babies hardly ever have the myotonia, but can look for the characteristic face in mom and try the myotonic maneuvers to see if mom has myotonic dystrophy. Children with myotonic dystrophy that are born with it have decreased movements in utero due to the weakness, and they may be born with a really asymmetric face. One eye higher than the other. They may be born with club feet, hip dysplasia. As children, they have difficulty speaking late, difficulty swallowing, and even like 14-year-old kids with myotonic dystrophy that are walking and may still have a lot of gurgling when they speak because they're not handling their secretions well. And then the usually mild intellectual disability. So in early days, my attendings used to call this a mall diagnosis. That is, you could recognize these kids in a mall. And these are just 2 more examples of kids with myotonic dystrophy. They have not had the the foundations working for myotonic dystrophy as strongly in the past as we had for for Duchenne or for SMA, but that's gradually changing. And there are several neuromuscular people in this country who are just working on myotonic dystrophy, and hopefully we will have some kind of a treatment soon. So in summary, although these are all uncommon conditions, together they add up to the point where you might see them. Multiple causes from the brain to the muscle to the bones, and primary care providers are the first line of defense to find these conditions early. For some of these, there are now treatments, and kids should get into specialty clinics, acknowledging that is hard, but acknowledging that they are trying very hard to be available for PCPs all over the country. Some are treatable, and one SMA is an emergency. The earlier we treat it, the better those kids do. So the red flags that you should at least be thinking about when you see normal infants and children are whether their weight and height are appropriate, are they developmentally appropriate, how's the resting tone, particularly in infants, looking for a symmetry of movement and their strength, and then, of course, looking for any decreases in abilities and strength over time, which might signal an ongoing condition. There are different areas for referral. For newborn screening conditions, the State Department of Health will help. It's a little different in every state. For the nerve and muscles conditions, MDA, Parent Project Muscular Dystrophy, and Cure SMA, and they really will be helpful. Those kids are also candidates for the early intervention programs, as well as kids with developmental delays and non-muscle related delays using the early intervention programs. And here are the websites. You guys all got my slides. And any questions?
Oh, thank you, Dr. Kerr. That was really interesting, particularly the cases I thought were very instructive. Thank you for that. And I'm sorry I didn't answer before was muted. I was muted and I didn't unmute myself before you went on, but I didn't see any questions at that time, and we're open for questions now. And you can put them either in the chat or the Q&A. I have one question. Because myotonic dystrophy is fairly common, is it more common in particular groups of people?
No,
No?
it is not.
Okay.
It's common, like if there's a founder's effect, it might be more common in one city. We had somebody that came over with Brigham Young who brought the Mormons to Utah. I think I have my history right, but anyway, he brought a man that was a polygamist, and he had a bunch of children, and that was in the 1800s, and then they had more children. So we do have this one huge family here. But except for that, no, we see them in Asians, we see them in the Black population, none of which are real big here, but.
Right. Okay. Any other questions?
I also think that because of the intellectual disability that kind of runs with these families, they have not been as active in getting help as the other muscular dystrophies, and that is changing. But I think that's also really important to know that we really need to be looking for this more.
Okay. And I, with you, hope that research can continue, certainly for the disorders that need treatment and certainly cures.
It's very exciting,
Yeah.
but not as good as we had hoped.
Well, but at least there is some hope, I guess.
Yeah.
All right. Any other questions? And Dr. Kerr, are you also available as a pediatric neurologist for consultations within MAVEN?
I am.
Okay.
So
Well,
happy to help.
that's good to know. All right. Anything that you'd like to add before we close then and give people a few more minutes of their day?
Well, we can tell them about Doctors for America, which doesn't include just doctors and PNHP. You and I were talking about this to help patients continue to get what they need in this world.
Okay, that's Doctors for America, and I'm sure they have a good website.
Yes, and PNHP, which is Elizabeth Warren's group from the East there, working to get better medical plans for all patients, insured or not.
Okay, PNHP. Okay. All right. Well, thank you very much. I think we'll close the session for today. And it was a great lecture. Very, very interesting. Thanks again.
Thanks. Bye-bye.
Bye-bye.